Hello, my name is Howie Choset, and I'm here with one of my partners, Jason Rose, in our company called Omnibus Medical Devices. We want to make medical devices that are accessible to everyone. Our beachhead device is a new ventilator called RoboVent. What we've seen from the COVID-19 is that it really has exposed us to see how stagnant technology can limit access to healthcare. Even with this highly contagious respiratory illness, where proximity to properly treat patients expose providers to disease and put stress on resources, we learned this from the recent COVID pandemic. What we want to do with Omnibus medical devices is we want to improve patient medical care, make patient care readily accessible, and preserve medical resources. In particular, not just PPE, but the people, the caregivers, perhaps the most precious resource who deliver the medical care. What COVID-19 has specifically shown us is at first there was a ventilator problem. Of course, current ventilators are quite pricey, and emergency ventilators weren't adequate to support the COVID-19 needs, as well as the needs of other respiratory illnesses. We also realized there's a limitation on ICU or the workforce, and the global situation was just far, far worse than just what was in the United States. There are fewer ICU providers, fewer technology available. But also in the United States, in low-income areas, rural areas, this problem is true as well. So what we want to do, is we sort of want to take the ICU out of the hospital, but we also want to improve the ICU in the hospital as well. We want to make a ventilator that works and is inexpensive, and we want to make sure the equipment integrates with existing technology as well as what we're seeing in telehealth. But what we want to do in the near term is make sure we can introduce some technology that may help the next COVID-19 surge. So what we want to do more specifically with the RoboVent is I think I'll let my clinical partner, Jason Rose, explain what the advances we want to make, because he's a medical doctor. He's the one on the ground really solving these problems.
All right, and I think so. We'll introduce the robotic ventilator, and so this is an actual video of our prototype that we've developed. So this is a fully featured standalone ventilator. The video is actually working on a Michigan test lung, it's called. The ventilator will have full connectivity to EHR and hospital networks, and it will integrate machine learning that guides patient care in real time that can help providers and researchers improve patient outcomes. The market on who's buying this, we have our traditional accounts in the United States, but we can also target emergency medical services like ambulances, looking at emerging and under-resourced markets, with some examples here, such as Brazil and India, or some countries in Africa even have a very poor ventilator penetration in military applications as well. And this is our Omnibus medical team with Howie and myself, including Keith Cook, Lou Lee, and Brett Zubiotti.
So I want to say this team really is an all-star team. Our skills complement each other both on the technology side as well as on the business and regulatory side as well. I also want to point out that we have a group of people who aren't from Pittsburgh, who came to Pittsburgh and want to stay here because we have the right combination of talent, and I think the ecosystem here is conducive for us forming this kind of company and making it a great success.
Thank you. Thank you. Great presentation, guys. My first question is, you mentioned that this was going to be more affordable and that it would work in low-income countries and you could use it on in EMS kinds of situations. Can you tell me a little bit about what you foresee the cost structure to be and what you could sell it for?
So our current projections are we will be able to sell this device for about between $1,000 and $1,500. And that's sell the device, it won't cost us to make that much.
Mm-hmm. And what will it cost you to make it? Do you know?
So we had a bill of materials which got us to around, I think, $300 to $400, but that doesn't include labor. And the $300 is a liberal estimate. What we've done, which I think is pretty cool, is we were able to rebuild some of the components using readily sourced materials. And it's one of the problems that the ventilators had was the sensors and other components were just hard to source. It really, COVID-19 tested our supply chain and it unveiled frailties in it. With our technology, if one supply goes away, we have an alternative one.
Okay, thank you.
No, thank you.
Hi, Howie. Thank you for that presentation. So my question is around the pandemic, and I'm assuming you all put this together in response to the pandemic. Am I correct, or was this something being made prior?
Yes. Yes.
Okay, awesome. So once the pandemic is over and there's no longer this level of need, how do you foresee this being used in other ways and to keep up the same amount of interest from whomever your purchasers would be?
This is a Jason question.
Yeah, so that's a great question. So COVID-19, we don't know how long it'll stay with us, number one. Hopefully it won't be with us too long, but I think if you look back the last 20 years, we've had the H1N1 pandemic in 2009, 2010. We had SARS-CoV-1, which was in the early 2000s, and then we had Middle East respiratory syndrome virus as well, which is another coronavirus in the mid 2010s. And Ebola virus. But essentially, I told you 5 global potentials for global pandemics. Unfortunately, I don't think it's ever going to go away completely. There's always a risk for pandemic flu at the very least and other coronaviruses. So I think that it's taught us that we need to be better prepared. So I think there's always going to be an increased demand for ventilators. But some of the numbers we showed, for instance, in certain countries in Africa, they have single-digit number of ventilators for millions of people in their population, which is certainly not enough to provide ICU care. And so I think there is truly a global shortage in ventilators when we look at low and middle income countries especially. So I think that that's never going away. And then going into the future, as we mentioned, ventilators don't integrate with telehealth, which we're using to stretch our current provider base, which for an ICU physician like myself, it took 4 years undergrad, 4 years medical school, 6 years of postgraduate training. We unfortunately cannot manufacture them quickly enough. So we have to spread our kind of scope with the providers we have. And so telehealth is one of the ways we're doing that. This ventilator would integrate with that. And then all of the opportunities with machine learning to actually improve patient outcomes, even beyond COVID-19 and what the outcomes were prior to COVID-19. Can we improve on that further?
And if I could add just 2 more quick points, I think the low cost will make it easier to disseminate this technology. So, let's face it, 47% of the people, prior to COVID-19, 47% of the people who went on ventilators in the United States, they died, but they died because they were sick, not because the ventilators were bad. And my hope is that this ventilator is so low cost that it will become accessible to people who normally would not have gone on the ventilator because it's such a scarce resource. So maybe we can derail the progression of a disease earlier on than normal. And then the other point I want to say is because we have this telehealth remote capability, we have also the ability to generate lots of data. So I think not only can we mine that data to learn how to develop better care, I think the RoboVentilator is just a beachhead application for Omnibus medical devices in general. I think we're going to automate the whole ICU and be able to generate data from all the machines to help improve patient care all around.
Fantastic. Great presentation and great team. My last question is, you talked about making it accessible and preserving resources, and Howie and Jason, you've just given some examples of that. How would you work with the providers, whether they're the primary doctors or the other healthcare service personnel, to train and be able to adapt to this system?
That's a great question. And so number one, I can say we're going to gain input from providers directly as we continue to develop the device. I myself am an end user of a ventilator. I'm an ICU physician and pulmonologist, but stakeholders like respiratory therapists, nursing staff, as well as emergency medical services, we plan to gain their input as we design this device. The aspect of it that it would be fully functional ventilator compared to some of the other emergency inexpensive ventilators that were coming out with COVID-19, if you actually look at one of those, they require a lot more training because that's not what we're used to actually using in the ICU. Not only can they not do as much, but it's the time-intensive training, and often it requires more bedside monitoring, which is exactly the opposite of what we would want. especially in a pandemic. So by being more like what we're used to, it actually lowers the investment as far as training and personnel time. And we actually can lower the amount of bedside interaction once you do get trained on the device. And it's going to be a simple, intuitive interface that is easy to operate by all providers in ICU taking care of the respiratory failure patients.